Hello, my name is Chris Fox, and I am professor and chair of the Department of Emergency Medicine at the University of California, Irvine. And I am really excited to talk to you about sort of my experience convincing the dean of the School of Medicine in order to be open to a curriculum in ultrasound and medical education, and also connecting me with a funding mechanism. So we'll go ahead and start. I have no disclosures, and this is me teaching, not teaching, but demonstrating ultrasound at the white coat ceremony. This is my dean right here. This was last year. And we were celebrating the fact that it was the fourth year of us giving out ultrasound probes to all of the medical students. So, in other words, well, now it's been 5 years. All medical students at the UCI School of Medicine have their own ultrasound probe. So I was doing a demonstration on stage. You can see there's Associate Dean over here, Dean Osborne. We can see Executive Vice Chancellor here. Anyway, and there's about 700 people in the audience watching me perform an ultrasound on a standardized patient and showing them how it works on a handheld ultrasound machine, trying to get everybody, excited about their curriculum. So anyway, so how the heck did I get to this space? I mean, it's pretty amazing when you go on our website and you see, that that the school has really wrapped its arms around ultrasound in medical education. And yeah, so what happened? How did I get here? Well, here's what happened. I back in 2010, I was I made an appointment with the then dean, uh, Dean Clayman. He's a urologist, and I just got on his calendar. I didn't ask for permission. I just contacted the person that does his calendar. And next thing you know, I'm in his office like a month later. I'm in his office and I bring an ultrasound with me, the most portable one I could find at the time, which was a Sonosite Nanomax. And I brought a volunteer, like a standardized patient. And that person just laid down on his desk and I performed an ultrasound on as many organs as I could until he interrupted me and he wanted to scan the kidneys and the bladder because he's a urologist. And so I talked to him about, I think this would be great for medical students to learn this. And he was just kind of sort of taking it all in, didn't really ask any questions. That was on a Monday. On a Friday, he called me up and said, "Hey, I can't stop thinking about that meeting we had on Monday, and I've got some ideas about how to get some funding." And then he followed up with this email that he has interest in making this device an integral part of every medical student's black bag. I truly believe this is the future and also want to see these devices in every exam. And that was my understand. That was my link into a top-down approach to having ultrasound integrated into medical education. It was a stroke of luck that he, happened to be just an open-minded dean and thought this was really cool. And then also, and I think this is probably the most important take-home point of my talk, is that deans, they have to make money flow from donors to projects. And so the more money that they can raise and connect that to the people doing the projects, kind of, that's their scorecard as a dean in many ways. And I understood that right away because he immediately contacted me like another week after this because he knew about this foundation, the UniHealth Foundation, who he had worked with several other cool projects. And he said, "Hey, I know the director of this foundation. You should meet with her." And introduces me to this woman, and I give a half-hour presentation. And next thing I know, I had $630,000. And then 3 years later, round two, $750,000. But it wasn't until, it wasn't unless I had that vetting from the dean that I had that ability to just suddenly be giving a presentation to somebody who leads a foundation. And so that's why I think it's so important to understand that kind of frame of the dean. And when this money changed hands from UniHealth to me and my team to start to integrate ultrasound in medical education, that fell under the scorecard of the dean for making that happen. So we all had a huge win with this. You just have to sort of understand that. I think one of the things to do is, think about some of the literature that's out there. When you go meet with your dean, you could be asked a whole host of questions. And so I'm just going to walk quickly through some of the formative papers that you might want to be aware of. This was a survey that basically 10 years ago that about a quarter of the schools in the United States had a formal curriculum. And then you fast forward to this article here, the New England Journal of Medicine, and again, a decade-old article that said point-of-care ultrasound medical education, stop listening and look. And here's a quote from that article: "A generation of physicians will need to be trained to view this technology as an extension of their senses, just as many generations have viewed the stethoscope. That development will require the medical education community to embrace and incorporate the technology throughout the curriculum." Now, I know that the whenever we talk about point of care ultrasound, and somebody says something about the stethoscope, it's a little kind of overplayed, a little cringy, but that's how a lot of people outside of our community understand it actually, and so I sort of give them a pass and play into that a little bit. If that's going to help them get excited about it, then great. And then so that was in the New England Journal of Medicine in 2014, a decade ago. This is a really nice thing to say. Hey, look, this has been out there for over a decade. Hey, we're falling behind the ramp here. And then in 2015, this was a cool article in the Journal of Ultrasound Medicine that said, hey, look, if you get some good ultrasound training in medical school, if you get a nice longitudinal 4-year curriculum in medical school, guess what? When you get to later in your training with residency and fellowship and beyond, you are going to really lean into this modality in a way that others just kind of don't have the time to do. And so this is just a nice sort of way to say that this really prepares students for beyond. This is a really tangible thing that they're going to use the rest of their life. And then also in 2015, we published the medical student core clinical milestones. And so these are like 90 milestones. So if you're wondering, gosh, where is ultrasound going to fit my curriculum? What are some things to learn that might make sense for me? Not that you'd have all 90 core milestones, but at least you have a nice smorgasbord there to choose from. And then in 2016, we published our own curriculum at UC Irvine, how we implemented our 4-year point-of-care ultrasound curriculum in an LCME accredited United States medical school, and you can read about our curriculum there. It's since evolved from that spot, and if you're interested in a more evolved version of that, feel free to reach out to me, and I can provide that for you. And then in 2018, in the Journal of the American Medical Association, JAMA, and this senior author here, Eugene Braunwald, probably one of the most famous, if not the most famous cardiologist ever, says, time to add a 5th pillar to the bedside physical examination. In addition to inspection, palpation, percussion, auscultation, now we have insonation. I love this article. I love that it got published in JAMA, and it's got such a big name associated with it. And it really does bring across that concept of insonation, or using ultrasound to look past the skin line to see what's going on in the body. It's such a cool concept. Anyways, in 2019, just so you can get a sense that this is really on my dean's radar. I mean, look at this. This is my new dean, Dean Stamos. He's a colorectal surgeon. And he says, hey, do you have anything to report from that handheld ultrasound project? Can you send me 1 or 2 slides on it for me to highlight our innovations and raise some money? I mean, if that doesn't speak to this frame that I'm trying to get across, I'm not sure what does. So my first dean, Dean Clayman, the urologist, says, hey, I can make some money flow between this foundation and this cool project. And then my new dean says, hey, I've got some donors. Let's see if we can raise some money. And now the machines are much less expensive than they were, back in 2014 and 2019 and 2020. We know the cost is coming way, way down for handhelds. And you know what? Maybe it's not just one donor or foundation. Maybe we get a whole bunch of donors, alumni who are like, can play in that $2,000-3,000 range a little bit easier. And so actually, this has made even sort of more funds flow this way because of the way the cost is structured slightly differently. So so that's the frame of these deans. They gotta highlight some innovations to raise some money. And then in 2021, I love this article. This is another good one to kind of have under your belt, so you can really see how a curriculum sort of starts out, and then longitudinally, they describe, Dr. Glass and his colleagues describe how at Wake Forest University started out, in anatomy and physiology, and then it started to evolve into pathophysiology, pathology, and then into the third year, and then into the fourth year, and then after several years of experience, now they have a much more, embedded longitudinal curriculum. Start out anatomy. After a few years, you end up with a 4-year curriculum. So that's why this was a cool article and really mimicked my own experiences as well. In 2023, we see this International Consensus Conference recommendations on ultrasound education for undergraduate medical students, and the QR code is there for you. Basically, this was a huge consensus. We did the modified Delphi approach and had 3 rounds of discussions and voting with people from around the world who are into ultrasound medical education, and lead author Dick Hutman, who was the dean at the University of South Carolina, and basically came up with a really nice curriculum about the components that should be in a longitudinal curriculum for ultrasound and medical education. And so this is kind of the last word on it, so to speak. And so I know I've been giving you some historical features that are running up to this, depending on the situation and your communication style and the time you have. You might want to start with this one and then work your way back, depending on your situation. So what else is going on? Well, recently, this year, 2024, 3 interesting articles came out. One of them was the efficacy of handheld ultrasound medical education, and basically they just sort of described, in a nice narrative way, what's kind of out there in terms of handheld education in medical school. And then this article here, integrating self-directed ultrasound curriculum for the internal medicine clerkship. These are medical students, typically in their 3rd year of medical school, who are rotating on internal medicine. And they basically said, here's some machines. Here's some asynchronous learning. So you could watch these videos, do some simulations, and then you could just start scanning. And it's very self-directed. You don't have somebody at the bedside looking over your shoulder. Your images are being saved and they can be reviewed later, but this is a very self-directed curriculum here. And one of our faculty at our track, you can see here and there, Dr. Cotton was one of the co-authors. And then finally, development of a hybrid point-of-care ultrasound curriculum for first-year medical students in a rural medical education program. So basically, they looked at, you may have this may be helpful to you if you have some rural locations where your trainees are in medical school. And this is looking at how they also had a curriculum, an asynchronous way to learn in a rural area where they would save the images that would later get reviewed. So this was 3 articles that came out this year in 2024. All right. I think another language that's helpful to know about that I see everywhere now, we call it curriculum speak. When you speak to your deans of the curriculum, they use this term a lot, called EPA. EPA stands for Entrustable Professional Activity. Entrustable professional activity. And EPA number 10 is recognize a patient requiring urgent or emergent care, initiate evaluation and management. And that's exactly how we use point-of-care ultrasound, right? It's like you're using it in the diagnostic phase in somebody who is, really sick and or even potentially sick. And then you're using it to help guide therapy. And so at its very core, this entrustable professional activity really screams at the need for having ultrasound integrated into the curriculum. So that's how we do it at UCI. And also at UCI, just to show you our curriculum briefly, in the first year of medical school, when they're learning the history and the physical exam for these types of systems here, on that same day, they also learn ultrasound. And so if they're learning about, the gastrointestinal system, the physical exam, they learn about what intestines look like and sound like with the stethoscope and the physical exam. They're learning it in anatomy, and they're also learning what it looks like on ultrasound. So so on and so forth. In the second year of medical school, they move on to more of the disease states and the pathology, and it's really the same systems. Just now we're talking about pathology and doing a lot of cases, and in those cases we have ultrasound integrated both with simulation and with standardized patients. So they're getting a lot of hands-on exposure in that first 2 years of medical school. And when I ask my medical students, really where was the meat and potatoes of how you learned how to pick up the probe, plop it on a patient, and feel confident getting organs to pop on the screen. Where did you learn those superpowers? At what point in the curriculum? Was it the third year, the fourth year, the second? They all say it was in the first 2 years. So I think that's why it's good to get that base down. But when you get to the third year, we need to connect to our patients, our students, to this generation. And so I've got some folks working with social media and putting together in our third year curriculum, we do some teaching through Instagram and so that they can follow this stuff easily on Instagram and get some good nuggets of information that my team put together. I didn't have a role in this; they did all of this, and I could not be more proud of them. These little Instagram posts came out just absolutely amazing, and you're not hearing the music and the stuff behind the other stuff that goes into making these posts really cool. But because they uncover a patient with a pericardial effusion, and they might be all by themselves in the room, and all of a sudden their patient's got a pericardial effusion. They're like wondering, uh-oh, is this tamponade or is this an infusion? Do I need to find somebody to help me right away? Is this patient about to become unstable? And so having some of those quick teaching pearls in here, in little bite-sized chunks, like the students tend to get a lot of their sort of knowledge nowadays, is really helpful. Here you can see we're talking about the EFAST. Our third year medical students are the driving force behind all of the fast exams that occur in our level 1 trauma center. They're the ones with the probe at the bedside, virtually 90% of them. So they feel very nervous doing that, but they also know that they've been trained very well. And then in the fourth year of medical school, there's this period between match and graduation where, March 17th-ish, the students match and they find out what specialty. They find out if they're going to be a family doctor or a pediatrician or, urologist. And then they don't graduate, though, for a few more months until, June. And so we've got, some, March, April, May, part of June there, and we know what kind of doctor they're going to be, and now we can focus on the types of ultrasounds that they would be, most likely to use in residency. And so that's when we can do a little bit more training with them and get them some really good just-in-time training before they head out the door. And we also have a whole ultrasound-guided peripheral IV certain credentialing process that they are welcome to opt into. I don't know. I've got a whole bunch of examples that I could show you. We could have a whole hour's worth of just cases that medical students have picked up, and or emails that I have gotten from medical students of cases that they've done in residency or maybe in on their sub-intern, rotations when they're trying out, to be a resident at another institution, or emails I get from faculty at outside institutions or my own institution, just to show you the kinds of things the students are able to do, and it goes on and on and on. But I only have 20 minutes on this talk, so I'll just show you one case. This was a second-year medical student whose roommate had abdominal pain, and they got to thinking, hey, maybe this could be appendicitis. So he uses their handheld, the second-year medical student has a handheld ultrasound device, and goes ahead and does an ultrasound. And you can see the psoas muscle down here. You can see this non-compressible tubular structure here, the appendix, and sends me this image, says, hey, I think my roommate has appendicitis. And I look at this image and I'm like, yep, let me call the ER. And I called ahead, and the patient arrived in the ER and went to the OR that night and had true appendicitis. So the roommate was a PhD student. So you got the MD student doing the ultrasound on their PhD student roommate and picking up appendicitis. Pretty cool. So yeah, a lot of this happens. One of the concerns you always hear about is, what if there's a false positive, false negative? What if students miss something? What if students are driving a whole bunch of unnecessary imaging? What if they're finding incidentalomas that don't matter? In doing this now for, really, the better part of 15 years almost now, we haven't had any drama or cases where there's been a problem with incidentalomas or missing cases or medical legal issues or billing issues or confusion here. I thought too that there'd be some of that, but at least it really hasn't. The one thing that comes up all the time, though, I will tell you, is the duodenum. When students first see a duodenum on themselves or somebody in their house or something was they've got their own machine so they can scan whatever they want. They think they see a mass in the abdomen and they send it to me. I get that probably more than anything else. I say, no, that's the duodenum, mid-peristalsis. So it looks actually like a lot like appendix. Another thing that's cool is that they can take these skills on the road and teach in other countries. And so I've had students go off to 20 different countries and not just, teach a group of doctors in another country, but also, leave behind machines for those countries to keep. So they go there for 4 to 6 weeks and train everybody on the machines that they're going to keep in that country. And that's another place that donors like to kind of be. And so you could get some donations and get some handheld products donated, and then the students go there and teach everybody how to use these. And I give them the exact curriculum that they learned from me. And while they're there teaching, of course, they have a faculty on site who's overseeing everything. But while you're teaching ultrasound, of course, you're learning ultrasound, so it makes them even better. So I'll just finish with this. This is really important that you understand where the naysayers. The naysayers are going to come at you from mostly this angle right here. Hey, our students are already distracted enough with technology. They don't need another thing getting in the way between them and their patients. These gadgets can be very distracting, and in fact, if you look at this picture here from the Journal of the American Medical Association, this was published in JAMA maybe a decade ago now. And it was a kid who was a patient. I think she was like 8 years old, maybe. She drew this picture. And it's funny because you can see the doctor is over here with their back, typing on a computer with their back towards the patient. She's the subject of this picture here in the middle, sitting on this gurney. And I think, there's like a family member, or maybe a nurse or somebody over here. And it's just the symbolism of the doctor with their back towards the patient as seen from a child's eyes is very real and very problematic. And that's where ultrasound necessarily forces you to put probe to patients. So when I did ChatGPT artwork for a medical student performing ultrasound on a patient, this is what ChatGPT decided to draw for us. So enjoy that bizarre picture. But I think it does get to the point that I'm trying to make, which is, a student needs to look at their patient, put the probe on their patient. Of course, the machine wouldn't be in the background; it would be in the student's field of view, and it would probably, and for my students, it's mostly a handheld device. But you get the idea. You got to put probe the patient, and then you can look the patient in the eye, maybe in not such a creepy way, but in a way that explains what their organs are on the screen and what some of their ailments might be. And that does quite the opposite of how people initially think about technology. This necessarily causes the student to come in contact with the patient and then do some patient education. So that concludes my talk. Thank you very much. And I'm happy to, you can contact me at jfox@uci.edu, and I'm really easy to find. I'd love to hear some of your comments. This was a picture of I wanted a student to draw the ultrasound revolution. And I don't know, maybe a decade ago or so, a student drew this picture of fists in the air, but they've got probes in them. So I thought that was a pretty cool artwork that Brian Lemieux, one of my former medical students, drew. Anyway, thank you very much.